So good afternoon, everyone, and welcome to Grand Rounds. This afternoon, we have the General Medicine Unit presenting on the pandemic of eating disorders during COVID. So we have Dr. Brooke Denyer, one of our general medicine specialists, presenting, and she'll be supported by one of our psychologists, Elena Pavlidou, and dietitian Jenna Wheatley. Thank you.
Thanks very much, Nicole. So we've titled this talk, The Pandemic of Eating Disorders During COVID. And really the reasoning behind this was there's been a lot of news articles recently about the increase in eating disorders during COVID, utilisation of healthcare services, hospital bed days and length of stay. And we thought it was timely to give a bit of an update on management and assessment of eating disorders. In the last 6 to 8 months, she'd stopped doing that. So she wasn't aware of how great her weight loss had been. She was an athlete and in an area that had a particular focus on body shape and body habitus. So she explained that she'd sort of started calorie counting as part of her exercise regime, and things had just sort of spiraled and progressed to the stage that she felt things were quite out of control at the moment. Like many of our eating disorders patients, she had a baseline sort of restrictive dietary intake. So for sort of unclear reasons, she was using a FODMAPs diet, which was fairly restrictive, and that was over several years. She'd recently started skipping meals. She didn't have any history of binge eating, purging, or laxative abuse, but she did have a lot of excessive exercising. There were significant intercurrent social stresses in her home life, which were exacerbating things. Symptomatically, her main symptoms were feeling very exhausted, and she was finding doing an exercise like climbing up hills, she was just getting exhausted and out of breath. She didn't feel dizzy, didn't have any palpitations. She had been amenorrheic for over a year. So on examination, she was bradycardic at 43. Blood pressure was okay at 105 systolic. Her other obs were okay. Her weight was 44.5 with a BMI of just under 16. Her bloods were actually not too bad, and this is also something that we can see on admission in our eating disorders patients. So she was mildly neutropenic, but otherwise her electrolytes were all within normal limits. Her ECG, of course, was abnormal at 40 beats per minute, which is either sinus or sort of junctional bradycardia, but had a normal QTC. She was hypoglycemic in the 2s and quite hypotensive overnight, resulting in a MET on her initial night. So the initial management was she did go to CCU for 24 hours of cardiac monitoring. She had a dextrose infusion for her hypoglycemia and multiple fluid boluses for her asymptomatic hypotension. This chart is just taken from our eating disorders protocol, which is all on the intranet, but it basically outlines our acute medical management about eating disorders patients. As you can see, it gives us sort of a really nice summary of things we ask about in the first week, the routine OBS that we do for these patients, and the bloods that we do on admission, and then every day for the first week. So you can see we sort of do daily bloods for electrolytes and daily ECGs and QIDB gels, and we sort of step things out for subsequent weeks of the admission. A bit of issues with again, taking from our eating disorders protocol, this is the routine sort of supplementation that we start for our patients. You can see there's a lot of sort of thiamine, zinc. We do things to look after their bowels routinely, lots of vitamins, and replace all the electrolytes quite aggressively. So as with all our eating disorders patients in hospital, we put them on what's called the eating disorders protocol that involves all the investigations and bloods, as we've seen, and early dietitian and psychologist input, which Elena and Jenna will go into in more detail later. We do have a weekly multidisciplinary team meeting with patients, carers, and all their key stakeholders involved in their ongoing care, including GPs, psychiatrists, if they're able to engage, and the Eating Disorders Hub. So the admission for this patient was for 3 to 4 weeks prior to discharge, and the plan was for follow-up with the Eating Disorders Hub, which is an outpatient service which smooths transition into longer care services for eating disorder patients. Unfortunately, and this is sort of unfortunately not uncommon with our patients as well, she did relapse within, a couple of months. Due to various missed phone calls and appointments, and also due to the patient herself feeling that the Eating Disorders Hub maybe didn't provide exactly what she was after. She didn't engage with the hub at all. She did try to engage with a private psychologist and dietitian, but faced issues with long wait times to get into them. So she came back again for another sort of 3 to 4 week stay, and this time we arranged closer follow-up with the hospital and the home team to smooth the transition out of hospital before she could get involved with the Eating Disorders Hub, and by that time she had a private psychologist and dietitian involved in her care. I'm just going to hand over to Eleni for the next part of the talk. Any questions so far about things?
Just Brooke, can you comment on the weight gain she had or had?
Yeah, good point. I think she gained maybe 2 or 3 kilos, didn't she? It wasn't an enormous weight gain, but I think the focus was more on a sort of sustained upward trajectory and sort of turning around. She had a lot of issues with missing meals, delaying meals for hours and hours. So getting her meals on time was a huge focus for her. So I think she'd probably only gained a couple of kilos by the time she was discharged, not an enormous amount.
And it was above her BMI.
Yeah, I can't remember what the BMI was actually on discharge. Sorry, but yeah, but it, it would have been 3-4 kilos, I think, before we discharged her. Yeah. Beautiful. Family history? Yeah, so no significant family history that we knew of mental health disorders or eating disorders, which is quite a sort of significant risk factor. Yeah, so no family history would sort of, would lead to her having an eating disorder per se. There was a lot of family dynamics going on, which she said sort of drove this desire for control, and part of the difficult family situation was sort of driving the eating disorder, but not in terms of a family history of similar things at all. Great.
So we thought it is important to sort of present a little bit what we usually do when we have inpatients in the hospital. So basically, the main goals of our admission is to make sure that the patient is medically stable, that they have adequate nutrition intake, and we look at weight restoration. So usually with our inpatients, we see them when they're very, very, very severely malnourished, and our protocol is mainly for anorexia nervosa patients. While we look at those specific goals, supporting them, from an emotional and psychological point of view is also very important for those patients. So how do we approach the goals of admission? Because the one thing that we all need to remember is that the Canberra Hospital does not have a specialized eating disorders unit. So we can say we're a specialized service because we have dedicated sort of staff members that are trained and qualified to look after our patients, but we're not a specialized unit. So we are on the Gen Med ward, and there are a lot of other people there that have no eating disorders, that have other issues. So what we came up with a specific sort of protocol and guidelines, and what we want to make sure is that the patients and the families, when they come in, they have a little bit of a structure. So on our intranet is our flyer that we've created several years ago, and it's an approved flyer. And the main sort of point that we really want to highlight is that it is a multidisciplinary approach. We do not see the patient in isolation or in silo. So what we usually do after they come into ED and then the decision is made for them to come onto the ward is that we orient the patient and the family to the ward with our flyer. So because they're overwhelmed, they're not likely to remember anything. So in the case of our patient, when I saw her first in CCU, she was overwhelmed. She was crying when I approached her. There was too much going on. So it was good for her to have something in writing so she could go back and see, okay, this is what's going to happen. These are the people that are going to look after me. So we utilize all those existing guidelines and protocols, and we are very strict in remembering new people on our team that you always need to go back and see what the guidelines say. What is the protocol saying? As I said, we highlight the weekly MTT meetings and their purpose. So why do we have those meetings? Because we do see the patient as an active participant. We do not want to make decisions for the patient, but we make decisions with the patient. The decisions that need to be made may not be what the patient wants, and we explain that, but they're still being made with the patient in the room every week, and we have a specific day, so it makes it easier for our team members to know that that time is really for those MDT meetings with our eating disorder patients. From the first meeting, we try to plan discharge for this patient so they know that they can look towards, something to work towards, their specific goals. We do highlight that we need to be very consistent, very reliable and dependable in all interactions with this patient, and we make sure that we don't make any decisions outside of this MDT meeting. Because of the characteristics and the personality vulnerabilities of these patients, there's a lot of staff splitting, and also family splitting. So we need to have this, to consider all those things. We do provide the supervised meal times, the nutritional support, psychology, skills classes. And as Brooke said before, we do liaise with a lot of other agencies because part of the MDT, part of the multidisciplinary team is also the GP that looks after this patient and probably has referred them to hospital. The clinical hub, any private clinicians that see them in the community, they are part of the team. They are invited to those weekly meetings via WebEx because we understand it's not easy for somebody, to just leave their practice and come to see us. I will come back later, but I'll give the floor to Jenna now.
Thank you. So just to speak a little bit about NGT feeding and when it's indicated. The idea is to aim to normalise eating patterns. So we always try and go for a food first approach, but there's certainly situations when NGT feeding is indicated. So for example, patients with a very low BMI or extreme risk of refeeding syndrome, or if patients are unable to meet their meal plan and unable to consume their nutrition boluses. And I'll speak a bit about the meal plans and nutrition boluses a bit later. So yeah, there's certainly situations where NGT is strongly indicated, but for a lot of cases, there's lots of pros and cons to consider when considering an NGT. So some of the pros, obviously, it can provide increased calorie provision and hence faster weight restoration, and this can actually shorten an admission. The controlled delivery of carbohydrate can reduce the risk of reactive hypoglycemia. And some of the cons to consider, an NG tube can be a source of great anxiety for some patients, and that may result in sabotaging behaviours and maybe, have them take a step back in their recovery. So it may actually be a step back rather than forwards. The other thing to consider is it can result in tube dependence. So, while it might shorten an admission, we don't really know if that can result in a higher chance of readmission later. So remembering that the aim is to normalise eating patterns, and that tube dependence is something that we want to move away from, because it's not really a suitable outpatient feeding approach. So just a bit about refeeding syndrome. So refeeding syndrome is the term used to describe the adverse metabolic effects and clinical complications when a starved or malnourished individual commences refeeding. So what actually happens is that during starvation, intracellular electrolytes become depleted from fat and protein catabolism. And then once refeeding is started, insulin secretion stimulates an intracellular uptake of electrolytes, and this can lead to derangement of serum electrolytes, particularly potassium, phosphate, and magnesium, as well as thiamine deficiency and salt and fluid retention. So if refeeding syndrome is not managed appropriately, this can lead to life-threatening complications such as cardiac failure, arrhythmia, delirium, and seizures. So anorexia nervosa patients are among the high-risk groups for refeeding syndrome. Other populations include elderly, oncology patients, and chronic alcoholism as well. In terms of the prevalence of refeeding syndrome, there wasn't much data reported on this, but I did come across a retrospective study that was published earlier this year that showed 6% of moderate to severe cases of participants in the study of refeeding syndrome, and about 22% of mild cases of refeeding syndrome. So in terms of identifying the risk, we use the NICE guidelines. So a patient would need to have any one of the criteria in the top list. So a BMI of less than 16, unintentional weight loss of more than 15% in the past 3 to 6 months, little or no nutrition intake for greater than 10 days, or low levels of potassium, phosphate, or magnesium prior to feeding. So this is pretty much every anorexia patient that's admitted onto the ward, or they need to have 2 of the lower criteria listed on the slide. So in terms of managing refeeding syndrome, from a nutrition perspective, we usually commence feeding at no greater than 50% of nutrition requirements, and then gradually progress feeding whilst monitoring electrolytes. However, in the eating disorder setting, this conservative management approach needs to be balanced with the risk of underfeeding patients. So there is a lot of evidence to say that we can rapidly refeed eating disorder patients in the controlled setting with medical supervision. So ensuring that prophylactic supplementation has been commenced, as Brooke presented on earlier, so thiamine, multivitamin, zinc, and phosphate. Sometimes, in some cases, IV supplementation might also be required. So yeah, we provide those supplements at the same time as commencing refeeding, and this should be continued for at least the first 10 days of refeeding, but it may need to be required longer. So we monitor electrolytes daily for the first week, and then if there aren't any electrolyte derangements or they've remained stable in the second week, we can reduce that to 3 times a week. So the clinical symptoms of refeeding usually occur within the first 5 days of commencing feeding, but it can actually happen from up to 2 weeks after. So just an overview about the nutrition interventions that we do on the ward. So as I said before, we aim for a food first approach. So we have a variety of set meal plans, and these will often change throughout an admission as the patient progresses. So as they do gain weight, their nutrition requirements increase. So therefore we move them up in meal plans. We use colours as names to avoid kilojoule and calorie content can be quite confronting or a source of anxiety for some patients, so we identify them by names. And we always provide the patient with a meal plan and a copy to the nursing staff as well, to assist with supervised meals. So this is an example of what a meal plan looks like. So it always has 3 main meals and 3 snacks because we want to promote regular eating. We don't allow food from outside or negotiating of meal times. So the meal times are the same as the rest of the hospital. We aim for supervised meals to prevent some of those behaviours like hiding food or throwing food in the bin. And if a patient is unable to eat a full meal or snack, then we provide what we call a nutrition bolus, which is just a 40-sip supplement that they need to finish if they're unable to eat the meal. So we try and use these as a sort of a motivation to eat the meal, because often they don't want to consume the supplements. So I'll just hand back over to Elena now.
Yeah. So while all this is happening for the patient while they come into hospital and they need to talk through the meal plans and everything else that freaks them out, from a psychology and also psychiatry perspective, the things that we need to take into consideration, but also from a medical point of view, are all those contributing factors. So we know that there's a significant genetic contribution to eating disorders. So quite often we have a family history. We know that there are a lot of interpersonal factors playing a role. So a history of trauma, is it bullying at school when they were younger, sexual abuse, physical abuse? There are a lot of personality vulnerabilities. So the biotemperamental sort of factors that current research is looking at. Of course, then we have the psychological factors, pre-existing depression and anxiety that always goes together with eating disorders. And of course, all the social factors, that obviously, we're all aware of the cultural pressures and the norms, glorification of, thinness, how we should look like, and, the role models that a lot of people are being fed through social medias. Brooke will later talk a little bit about the stats with regards to those contributing factors. In the case of our patient, there was no family history of an eating disorder. But the interesting thing with her was that one of her parents was a very domineering person all her life, and she had experienced psychological and verbal abuse for many, many years since she was a child. And there was also, as Brooke mentioned, the parents were going through a very, very nasty divorce, which of course for her, the only way to control the situation as a child, but also as an adult, was to control her eating. So as clinicians, what are the main considerations? And from our experience here at the hospital, I think the most important thing is to really be prepared and really educate, yourself as much as possible about what an eating disorder is, what are the contributing factors. We need to make sure that we are aware that the patients will experience very high levels of anxiety, of shame, of embarrassment, guilt, while they're here in hospital. They may also be in denial that they have any problem with their eating. It is also important while we look after the patient, and we may see some behaviors that are very, very challenging, to be aware of what's going on in the patient's sort of surroundings. Are they given the opportunity to be open, and be honest? Do they have opportunities to have sort of calm conversations and interactions with people? That doesn't include only, their family environment, but also while they're here with us. Do they feel safe while they're with us? Do they feel like we listen to their concerns? And also, one of the important things that, through my experience, I think we should focus much more is to look at what is the role that the eating disorder plays within the family system, because none of us exists in silo. And quite often, if we try to focus only on the symptom and fix the symptom, we don't really go into what is the actual cause of it. So having a look into the whole family system and how the eating disorder developed and what the role of the eating disorder has been for this person may open up more pathways for us to recommend specific treatments in the future. Some of the sort of challenging behaviors that we will see on the ward, and that's why an MTT approach and really, you know, following the protocol and being very consistent is important. It's because, as Brooke and Jenna mentioned, there are a lot of those challenging behaviors that we can see, like, you know, I said before, staff splitting, it's huge, agitation, difficulties with any change and high levels of distress, non-compliance with bed rest, you know, when we, you know, tell them what they ideally should be doing and not be doing, tampering with feeds, fluid loading. All these are very challenging behaviors, and they're very much ingrained eating disorder behaviors and thinking patterns that we need to look at. At the end of the day, we are fighting the eating disorder. We're not fighting the patient, so we need to be aware that those behaviors can create some reaction in us as clinicians, and we need to be able to know how to approach that. And of course, suicidal ideation, possible active sort of self-harm, you know, cutting themselves, you know, scratching themselves, all those can interfere with how we work with this patient. If we look at how these patients' thinking patterns have become very, very rigid, we need to talk about the staffed brain, because when we have a staffed brain, we have impaired new learning. They're not able to take in or retain information, even when we tell them the same things, you know, every day. We know that they have impaired cognitive flexibility, so their thinking is not like, you know, somebody else's normal thinking patterns. There is, and we know from a lot of studies that they show weak coherence, and weak coherence basically is a very specific sort of perceptual cognitive style that describes, you know, an inability of the patient to understand the context and see the bigger picture. So they're very much detail focused, and they will focus on, you know, I can't eat that banana, I can't eat that yogurt. You know, they won't be able to see at the bigger picture of, you know, I'm looking at surviving, I'm looking at getting better. So that's not something they do deliberately. It's part of the staffed brain. You know, the social skills, you know, will not be, you know, very good there. They may not be able to regulate their emotions, and their distress can take over. So all this, it's important for us to know what we may see while they're with us, especially early days when we're still trying very hard to restore their nutritional intake. So for our inpatient psychology service, you may ask me, so yeah, if they are so compromised, you know, what is the role of psychology or psychiatry if they can't retain information? What do you actually do? Oh, yeah, food for thought for all of us. A compromised brain function and, you know, all those inefficiencies in their cognitive you know, abilities will pose a lot of difficulties in how we will try to support them and provide psychological interventions. But nonetheless, it is important that we are, you know, part of the team, psychology and psychiatry. Some of the more appropriate approaches while eating disorder patients are in hospital, not the more sort of standard approaches like, do cognitive, behavioral therapy. That just doesn't work with those patients because they're not able to take in that information. What has shown to be very helpful, and what we do here at the hospital, creating the opportunity for those patients to have skills classes or group sessions where they are together with other patients that go through similar sort of difficulties. Cognitive remediation therapy has been shown that it's very appropriate for our inpatients, especially when they have very, very low weight. It is a standalone pretreatment, targets those cognitive inefficiencies while trying to engage them sort of in interactions. It is a non-threatening approach, and that's the good thing, because we don't talk about eating during that session, and that enables them to actually basically engage with us, build that rapport, and sort of sets the foundation for hopefully for them later to engage in other sort of therapeutic settings. So it basically helps them to become ready for therapy. There's also emotion skills training that also enables the patients to maybe try to identify, label and express their emotions, because we know it's very difficult for them to have that connection with their emotions. And through emotion skills training, we can sort of teach them as much as possible, some other ways to regulate their distress, their high distress. We do that through psychoeducation, through anxiety management, or distress tolerance skills. And we may just repeat that again and again and again. We will use visual cues to just remind them, because remember, their cognitive flexibility and their ability to maintain this information is very much, compromised. Some other sort of approaches that we've been trying to introduce lately to utilize elements from some approaches that are a little bit emerging, like radically open dialectical behavior therapy, which is an approach that is used with disorders of over-control. If you look at anorexia nervosa patients, they have a lot of self-control. They have they are the experts in distress tolerance because they starve themselves. So having elements of that approach and making them a little bit more open to, to exploring different ways of dealing with the over control has been shown to have some successes. Within the peak body of eating disorders, the Australian and New Zealand Eating Disorders Association, this is one approach that is coming up, because all the other approaches, as I said, CBT and the specialist supportive clinical management, these are approaches for anorexia nervosa patients, but they're more for outpatient settings. So what we can do is take elements of those and introduce them to our inpatients, but introduce them in very small sort of steps, because remember, we are not a specialized unit where they can go later to, learn more about their condition and ways to deal, to deal with that. We are a very acute sort of service that tries to, first of all, keep them alive. And I'll give it back to Brooke.
Thanks, Eleni. So I'm just going to give a bit of a basic overview of sort of anorexia nervosa here, which, as you can see from this slide, there's more than one eating disorder, and anorexia is really a small part of the eating disorder spectrum. So in the Diagnostical and Statistical Manual of Mental Disorders, there's 5 listed eating disorders, of which binge eating is by far and away the most prevalent in society. It's approximated that of the 1 million people in Australia with an eating disorder, about 25,000 have anorexia, and that's what we'll focus on today. So as I said, during COVID, eating disorders have unfortunately been on the rise. There was a systematic review published earlier this year, which looked at all, 53 studies from 2019 to 2021 with over, 36,000 patients. This was a multi-centre study, mainly in Western nations, unfortunately. So North America, Europe, Australia, New Zealand, very small studies done elsewhere. But within these limitations, it did show a 48% increase in hospitalizations for eating disorders during this period. And 36% of patients in these studies had increases in their eating disorder symptoms. From the Australian perspective, we've seen similar things. So this was a 2022 study, which was an online survey during the first couple of months of the pandemic in Australia. Looked at 1,700-ish participants around the age of 24, 91% female. And I won't go through all the stats, but as you can see that these people self-reported significant increases in their body image concerns, restrictive food intake, binge eating behaviours, excessive exercise and this was just during the first couple of months of COVID in Australia. Just to highlight the bottom two stats, which is something that we see similarly in studies elsewhere, it found that 40% of people who self-reported things that would be consistent with a diagnosable eating disorder hadn't sought a formal diagnosis for this, and under 50% of these people were actually engaged in treatment, and that's sort of a flavour that we see across the eating disorder literature. So if we look at the actual diagnosis of anorexia nervosa, according to the DSM V, you need 3 criteria and you need all of them. So there's obviously restriction of your energy intake relative to your requirements, and that leads to a low body weight. And this is sort of an absolute sort of distinction between anorexia and bulimia. So we can see some overlapping behaviours between the two disorders, but bulimia people will have a normal body weight, whereas anorexia, the body weight is low and often markedly so. Psychologically, they have an intense fear of gaining weight or being fat, and they have behaviours that continually interfere with their own weight gain. And then they have this abnormal perception of their own body weight and their body shape. This is a, excessive, emphasis on their own body weight and body shape, and they don't recognise the seriousness of having low body weight. In fact, a lot of them quite attached to that image of themselves. There's 2 subtypes of anorexia that we see. There's the like the patient in our example, the restrictive type, where you just restrict intake. You can have excessive exercises, but you don't have this sort of binge eating, purging behaviours. You don't have laxative abuse, diuretic vomiting, all those sort of behaviours. The binge eating, purging type, you do have those behaviours, but as I said, these behaviours are similar in bulimia, but you have a low body weight in this subtype of anorexia. And it's defined with the levels of severity, as you can see below. So extremely low BMI is defined as under 15. So our patient in this example sort of had between 15 and 16. So it's say, severe anorexia nervosa, but not at the extreme level. But we certainly do see people come in with BMIs of 12, 13. So really, really extreme low body weight. The prevalence data varies a lot. So some literature will say that, 4% of women have anorexia. A lot of others say 1%. I've sort of gone with that. Not sure if it's correct, but it seems a lot to say that 4% of people have this sort of rare disorder. Men's obviously a lot less likely, sort of 0.3 to 0.5% of men are diagnosed with anorexia. It's a disease of the young, so 75% of people are diagnosed at a very early age, between 12 and 25 years. It's unusual to be diagnosed initially after the age of 25. So it's a significant issue in the paediatric population as well as the adult population. Obviously, with onset at this age, it disrupts a lot of sort of very pivotal life events, people's schooling, later schooling years, university trades, employment, and also fertility and family planning for these patients. So Eleni's gone into the risk factors a bit, so I won't dwell on it too much, but just to point out that there's an enormous amount of really, really interesting research into a multitude of risk factors for anorexia, including, biological and physiological things, as well as psychosocial influences on this. So we've had large-scale twin studies that have looked into the differences between, genetic and environmental exposures of twins and found that there is a strong genetic link. So large-scale genomic studies have found, specific gene loci are associated with anorexia. We know that you're much more likely to develop anorexia, some say up to 11 times more likely if there's a relative with anorexia as well. Age, as I've mentioned, puberty, so whether it's a hormonal relationship and also with it being female, you know, people who have early onset of puberty also develop anorexia earlier as well. A lot of comorbidities, and as Elena's alluded to, so these people are often very perfectionistic. Obsessive compulsive disorder is sort of, you know, quite a common comorbidity in these patients, as well as, you know, depressive symptoms and other things like schizophrenia, autism, and, you know, obsessive perfectionistic personality traits. If you have the binge eating subtype, then impulsive personality traits are also associated with this. A lot of research as well into the gut microbiome, sort of chronic gut infections, certain proteins released from E. coli. There's some sort of fascinating research into the role that that may play in the development of an eating disorder, especially with people having early satiety despite low intake and low body weight. So that's sort of in the pipeline. There's possible associations with autoimmune and inflammatory diseases, particularly of the gut, like celiac disease seems to be really high prevalence in patients with anorexia, inflammatory bowel disease. There's also a lot of research into the association with type 1 diabetes and whether or not this is increased in patients with anorexia, or whether it just sort of comes to the fore because these people are very difficult to manage. So if you have type 1 diabetes and you don't want to gain weight, then they stop taking insulin or they diet, and that plays up with their diabetes. So there's some really interesting literature on that as well. Some research into intrauterine hormonal exposure with multiple hormones, older maternal age and low birth weight maternal health complications as well. Childhood weight, some contradictory data. Some data says that if you're always a low BMI child, then you're more likely to just go on the sort of abnormal eating patterns and develop full anorexia. Some say that if you have a high BMI, a child with a high BMI, they may get bullied, and that in turn is associated with developing an eating disorder. So that's not quite clear cut there. As Elena's mentioned, childhood trauma, parental characteristics and parental eating habits, especially, it's making me a bit paranoid as a parent, but how you communicate about food to your kids, what comments parents make about their children's weight, really, really strongly associated with eating disorder development and eating patterns in that child. Income is traditionally, anorexia has been seen as a disease of high income, white, well-educated people. In fact, there's no sort of consensus on, you know, higher income people being more prone to develop anorexia. There's possible association with higher educational attainment in the patient and the parents. Elena's mentioned sort of social media and societal factors that espouse sort of the thin ideal. Involvement in elite sports. Certain elite sports is, as with our patient, shown to be a bit of a risk factor. Ethnicity, again, there's not good data on this. Traditionally, it's been seen as a disease of sort of more, you know, white populations, but the reality is most of the research has been done in these populations. And there's also concerns that people from culturally and linguistically diverse populations are possibly less likely to report these due to shame and stigma. So I don't think there's any clear evidence. There's not a lot of evidence in these culturally diverse populations in Australia at all, unfortunately, to guide this. Medical complications are protein. So the main sort of life-threatening things that we worry about are, of course, cardiac arrhythmias. And of that, we most worry about prolonged QT syndromes. That's often associated with electrolyte derangements, sometimes psychotropic meds, and sometimes just sort of increased vagal tone and attempting to conserve energy and influences of that on the ECG. You can see echo changes, so low ventricular wall mass, pericarditis, apparently, you know, very common if you scan all these patients. There's a lot of dermatological changes. I won't go through them in too much detail. GI symptoms, something that we see commonly, so these people often have really slow transit in their gut. They have a lot of complications. You can see gastric dilatation. Sometimes we do, you know, we x-ray these people's abdomens and they do have really marked sort of colonic and gastric dilatation. Hepatitis can be seen before people come in as a starvation phenomenon, and also the LFTs often worsen during the refeeding times. That's something we track with refeeding as well. There's a lot of endocrine abnormalities as well. So amenorrhea, sort of well recognised in these patients as a sort of energy conserving method. Osteoporosis is something that we always worry about in these patients, and it's difficult to manage because starting anti-resorptive therapy in someone who's, early 20s is problematic, and it's something that I would just say best left to the endocrinologist and the specialists, but we do sort of DEXA scans and follow up for these patients to monitor their bone health, supplement with vitamin D and calcium as needed. But that's a very complicated topic. We often see hematologic abnormalities in the bloods, particularly neutropenia, but actually in the literature, it's not particularly associated with increased risk of infections, luckily, but we do often see this as sort of bone marrow suppressive effect of the starvation. There's been some research on MRIs in these patients, and we do see that there is some cerebral atrophy. And of course, it's hard to track whether this improves over time, but that's sort of an emerging area of research about the cognitive effects, short and long term, of the starvation on the brain. And of course, pulmonary issues as well with malnourishment and weight loss and spontaneous pneumothorax and risk of aspiration, etc. Does anyone have any questions? So far, I seem to give me a lot of data. Nope. I'll keep going.
Just to add some comment. Thank you very much for the very excellent presentation. Thank you very much for the excellent presentation. Just a few comments. From my experience, I noticed most of the patient sports, also static tachycardia, have an underlying eating disorder. And number two, comment, you mentioned that one of the complication or manifestation eating disorder is emphysema. In the new guideline now of emphysema, when they classify the chronic obstructive airway disease, they consider weight loss or decreased BMI is a risk factor for death. So if you have a patient with emphysema and eating disorder, and loss of weight from emphysema and from eating disorder, most probably the risk of this will be at least a double.
Yeah, no, that's a really good comment. I think obviously the malnourishment affects every organ system. Thank you. I'm aware we're nearly up to time, aren't we?
I think we are.
I've got a few slides left, but happy to just pull it up.
We might
in the interest of time.
We might just see if there's any questions in the chat.
Yeah,
I didn't
sure.
see any pop up. I actually had a question, sorry, while we're sorting that out, about I was wondering, given all the challenging behaviours, and these are adults, so they have their own will, I was wondering how often do you ever have to get an order to hold people against their will? Because if they've got severe electrolyte abnormalities and they've got a prolonged QT and you're worried about arrhythmias and things, is there some difficulty in holding people against their will?
Yeah, that's a great question. And so we do at times admit people involuntarily. It's often people don't want to come in, so they might come in for other reasons, and we notice that they've had this traumatic weight loss, or the parents are concerned, or GPs call us and they're concerned, but the patient doesn't want to come in. So what guidelines do we use to say you need to come in and we need to make that involuntary? It's guided a lot by what we call the marzipan guidelines, which are British guidelines. I think they came out over a decade ago, and they were in response to the recognition that people with anorexia were dying unnecessarily in England, and they released these really good guidelines. I can't remember what the acronym stands for, but it's the management of acutely ill patients with anorexia as an inpatient. The guidelines that they use are all on our eating disorders protocol, but it basically is a combination of sort of, critical BMIs, significant electrolyte derangements, issues with postural hypotension and tachycardia, so hemodynamic instability, ongoing hypoglycemia, or, prolonged significant weight loss over a period of months. And Ashwin, you can add anything else according to our admission criteria.
Yeah, I think it's clear what the physiological criteria for deterioration is, but the particular challenge is patients don't agree with us, they need to be in hospital. And rather than invoke the psychiatric mental health act under a detention order to keep people in hospital, I mean, sometimes apply for a psychiatric treatment order or a community treatment order to make people stay in hospital. And that's a real challenge because in the adolescent space, it's often the parent can give permission to give IV fluids or to insert a nasogastric tube, but when you're an adult, you have a much higher threshold. And essentially it's all about capacity. And if you have to show that the person does not have capacity based on a mental health issue, then you can apply for a PTO or CTO. Well, that is extraordinarily difficult because even if you've got one of those in place, it's very distressing for the nursing staff, medical staff actually to insert a nasogastric tube or keep the nasogastric tube in if the patient is pulling it out all the time. We've had to do bridles and all sorts of not good things. So it's a difficult space. This is one other question maybe for Brooke and Lady Tenser about COVID and social media. Certainly TikTok, which I'm not a member of TikTok, but I've heard that there's lots of anorexia type communities within showing a lot of videos about how to, hide food, or when you're in hospital, how to evade the nursing staff, and also just almost encouraging each other. Do you think this is a new phenomenon, and how do we manage it?
No, I don't think it's a new phenomenon. There are specific websites that eating disorder patients access to learn from other eating disorder patients. So that's been around for quite some time. I don't know the names. I'm looking at Claire if she knows the names. But yeah, it's all about thinness. But it's not because of COVID. It started far before COVID. That there are specific websites, and they're not open to anybody. There's a whole network there of how to, manipulate the situation in hospital or at home and what to do, And a lot of our patients in the past have followed those advice and recommendations. And I guess that's why it would be really important to have those so lived experience people maybe being a little bit more part of our treatment approach in hospital, the ones that have recovered, to include maybe some of those. And I know, Ashwin, in the past we were talking about, can we bring in, some of those patients when those people to talk to our patients. And I guess if we can't do it within an inpatient setting, the eating disorders clinical hub, I'm sure they're working towards including them more into the treatment therapy, because it's different to hear from somebody that has had the lived experience and how they dealt with those, issues and how they were able to sort of distract themselves, from that network of the glorification of, thinness. So hopefully, we do have a slide that shows you, and for all those that are online, the contact details for the Eating Disorders Clinical Hub, who's been funded to, continue the work after the patients go out in the community.
I think if there's no more questions, we probably need to draw it to a close now. But I think, there is another question.
Yeah, we have one in the chat.
Oh, we have one in the chat now. I can't see it. It just says, patients seem to be overloaded or overlooked in outpatient settings.
That's a good question, Elena. I don't know whether you want to answer this. It's about atypical.
Atypical.
So atypical means like,
in the
I think normal BMIs, but significant weight loss. To be honest, I didn't look into any data on that. I think these people probably are. The question was about atypical anorexia nervosa, where people have significant weight loss and disordered eating habits, but sort of semi-normal BMI, or maybe on the lower end or just in the middle. I think these patients would be harder to pick up, I think, because they have a normal BMI. There's probably not great data on how, common this is, but I must say I did look into the specific data on that.
I mean, there are anorexia nervosa patients that are that have bigger bodies. So it doesn't mean that, you're underweight and you have anorexia, but if you're not underweight, you're not. I guess we are relying a lot on the GPs to do all those investigations and, the medical sort of science to know there's something going on, you need, an admission. I don't think that the team would say no to an admission if we know that somebody is really unwell and has lost a lot of weight. We still would continue to do the protocol and help them with meal supervision and sort of other psychological distress that creates the problem in the first place. Yeah. So I'm sure if we had anybody from the clinical hub here, they would be able to talk a little bit more through any stats and the number of people that they see outside, because they're not picked up easily. I mean, I walk through shopping centers and each time I see somebody, I think, oh, there's another one, but it's only because you see it, but it's the number of those that we can't really pick up easily. Yeah.
And would you please all help me thank Brooke, Eleni and Jenna for this great presentation. It's obviously very topical, and I'm kind of just reflecting on the fact that it's such a lot of comorbidity for our community, isn't it? When we've got young, otherwise healthy adults spending weeks in hospital and then the outpatient morbidity too. So thank you.
Thanks very much.